In this video, I'll talk about the injuries of the lower limb covered in the MBBS curriculum. First, femoral shaft fractures. Femur is the longest and the strongest bone in the human body. Common causes of femoral shaft fractures in adults are road traffic accident and fall. There is a significant amount of energy transfer in causing a femoral fracture. For this reason, these are often associated with injuries to other limbs and organ systems. Femur fractures can also cause significant local soft tissue damage and hence lead to an open fracture. Large muscles surrounding femur lead to displacement of the fracture fragments, producing obvious deformities. In a femoral shaft fracture, the proximal fragment is flexed by the contraction of the iliopsoas muscle and abducted by the pull of the gluteus medius and minimus muscles. The distal fragment is adducted and pulled proximally by the adductor magnus, leading to shortening. In supracondylar fractures of the femur, the gastrocnemius muscle flexes the distal fragment and may lead to injury to the popliteal artery. Systemic complications associated with femur shaft fractures include hypovolemia and shock, fat embolism syndrome, adult respiratory distress syndrome, DVT, PE, and decubitus ulcers. Local complications include malunion with significant shortening, non-union, stiffness of the adjacent joints, and occasionally neurovascular injury. Management of the femoral shaft fractures in adults need careful evaluation and treatment of systemic injuries along the ATLS protocol. Specific management includes splinting and analgesia, followed by surgery. A closed femoral shaft fracture is best treated by an intramedullary nail, like here. An open fracture needs soft tissue management by the way of debridement, followed by an intramedullary nail, or rarely an external fixation followed by an intramedullary nail. Fractures around the joints are treated with contoured plates and screws. Pediatric femoral shaft fractures differ from the adult fractures in many ways. The thick periosteum limits the displacement and helps in early healing and quicker recovery. Deformities, including shortening and angulation, are well remodeled, leading to good long-term results. However, the open physis poses unique challenges in surgical fixation. For children, especially under the age of 1 year, it's important to be aware of the possibility of an intentional injury. Treatment in a child depends on the size and the age of the child. As a general guide, during the first few months of life, these can be treated either by splinting or in a Pavlov harness. From 6 months to roughly around 5 years, these fractures can be treated by hip spica application. Note the uniform molding of the plaster cast shown here. And now this has healed with an excellent callus formation as shown here. In those children who are under the age of 9 or 10 years or who weigh under 30 years, a titanium elastic intramedullary nail system, also called tense nails, are appropriate. Older and heavier children are treated with open reduction and internal fixation with plates and screws, avoiding the physis as shown here. Gallo traction, popular among the previous generation of examiners, are of academic interest only. Next is patella fractures. Patella is the largest sesamoid bone in the body, formed within the quadriceps tendon. It gives attachment to the patellar retinaculum, increases the lever arm of the extensor mechanism by about 30%, and also stabilizes the knee joint. Indirect injury leading to patellar fracture is by the way of eccentric contraction of the quadriceps muscle, and the fracture is usually a two-part transverse fracture. Here, if the muscle contraction is strong enough to fully tear the patellar retinaculum, the fracture gets displaced as shown here. Otherwise, it may remain as an undisplaced fracture. In direct knee hits such as landing on the knee or a dashboard injury, a stellate fracture may result. Most common complication of an untreated patellar fracture is knee stiffness. Instability, quadriceps weakness, and osteoarthritis are other complications. An undisplaced patellar fracture can simply be immobilized in a long leg brace or a cast for about 4 to 6 weeks and start knee rehabilitation. A displaced fracture is treated with a tension band wiring, which is based on the principle of generating compression at the fracture site when the muscles contract. The next topic is tibia fractures. Tibia is subcutaneous throughout and is hence prone for open fractures. When the fractures occur around the articular part of the proximal tibia, they are called tibial plateau fractures or bump fractures. When the distal articular part of the tibia fractures, it's termed the pylon fracture. Note the proximal fibular fracture here. Open fracture, as shown here, is an important local complication of tibial fractures. Untreated or inappropriately treated open fractures lead to infected non-union. Other local complications include malunion, compartment syndrome, and neurovascular injury. Systemic complications of a tibial fracture include hypovolemia leading to shock, fat embolism, adult respiratory distress syndrome, and DVT and PE. In addition, periarticular fractures can cause osteoarthritis and joint stiffness. Similar to femoral shaft fractures, fractures of the tibia indicate significant energy transfer and hence may be associated with polytrauma. Due to this reason, management of the tibial shaft fractures should be along the advanced trauma life support protocol. This is to recognize and treat the more life-threatening injuries on a priority basis. After appropriate splinting and analgesia, specific local treatment for most of the tibial shaft fractures is surgery. A closed fracture is treated with an intramedullary nail as shown here. Open fractures are converted to closed injuries by appropriate soft tissue management such as debridement, and either an intramedullary nail or an external fixator is used to fix the fracture. Periarticular fractures of the proximal tibia is treated by contoured plates and screws as shown here. Similarly, the pylon fractures are also treated by contoured plates and screws. The next topic is ankle fractures. Stability of the ankle depends on the intactness of the bone and the soft tissue anatomy. Bone congruity is produced by the two malleoli and the talus embedded deep within them. Ligaments stabilizing the ankle joint include the tibiofibular syndesmotic ligaments and the medial and the lateral collateral ligaments. Generally, the ankle fractures are classified based on the stability and hence decide appropriate treatment. One simple way to classify isolated lateral malleolar fractures is based on the intactness of the syndesmosis, like a stable injury which is infrasyndesmotic, less stable injury which is transsyndesmotic, and an unstable fracture which is a suprasyndesmotic injury. Here the lateral malleolus, the medial malleolus, the posterior malleolus with ankle subluxation is shown. Such injuries are prone for early skin complications such as swelling, blistering, and skin sloughing. Early close reduction, immobilization in a slab, limb elevation and ice application are all done to prevent such complications. Malunion, non-union and osteoarthritis with chronic pain are the long-term complications. Isolated lateral malleolar fractures which are otherwise stable are treated by plaster application. Unstable injuries will need surgical fixation. All medial malleolar fractures with or without associated lateral malleolar injuries are mostly treated surgically. Next topic is talus neck fracture. Most of the talus is intra-articular, either within the ankle joint, the subtalar joint, or the talonavicular joint, and hence it has no recognizable muscle attachments. It forms a key link between the ankle and the foot, with the body of the talus locked within the socket formed by the two malleoli. An important testable material in the talus is its vascular supply. Artery of the tarsal sinus is formed by the contribution from the peroneal artery and the anterior tibial artery. It enters the tarsal sinus under the neck of the talus to anastomose with the artery of the tarsal canal. Artery of the tarsal canal is the main arterial supply to the body of the talus. It arises from the posterior tibial artery. Enters the tarsal canal medially and anastomoses with the artery of the tarsal sinus. Other smaller contribution is from the deltoid and posterior tubercular branches. The arrangement of the vascular supply to the body of the talus predisposes it for non-union and avascular necrosis when the neck is fractured. Note its similarity with the vascular supply to the head of the femur and the proximal part of the scaphoid. Common etiologies of the talus neck fracture are fall from height and road traffic accident. Mechanism is forced dorsiflexion when an axial load is applied on a plantar flexed foot. Hence, it's sometimes referred to as aviator's astragalus. Talus neck fracture is classified according to the Hawkins method and is beyond the scope of the current syllabus. As I mentioned earlier, the common complications of these fractures are avascular necrosis and non-union. Both are due to a compromised vascular supply. This may further lead to degenerative osteoarthritis of the ankle and even the subtalar joints. As a general rule, in all fractures, an undisplaced fracture is treated in a below elbow plaster, and a displaced fracture is treated with open reduction internal fixation with screws. Next is the calcaneal fracture. This can either be an extraarticular fracture as shown here or an intraarticular fracture. Fall from height is the usual mechanism of injury. Malunion of the intraarticular fractures can lead to osteoarthritis of the subtalar joint. This manifests as pain and difficulty in walking on an uneven surface or a ramp. Key testable knowledge in calcaneal fractures are bolus angle and crucial angle of Gisene. Bolus angle is also called the tuber joint angle and is formed by the line joining the highest points of the anterior and posterior facets of the calcaneus with a line joining the highest points of the posterior facet and the calcaneal tuberosity. It is usually around 20 to 40 degrees. Bolus angle represents the calcaneal height and the position of the facets. Crucial angle of Gisene is formed by the lines drawn along the anterior and posterior facets of the calcaneus. It measures around 120 to 145 degrees and it indicates the integrity of the cortical strut supporting the talus. Here you can see that the bolus angle is reduced and has turned negative, and hence the calcaneal height is significantly reduced. Here the angle of Gissane has increased significantly. Calcaneal fractures are treated by rest, elevation, ice application, and sometimes support in a plaster slab. For significantly displaced fractures, surgery may be necessary. The last topic in this presentation is fracture of the metatarsal bones. Fracture in the fifth metatarsal base can either be a Jones fracture or a pseudo-Jones fracture. Jones fracture occurs at the metaphysis-diaphysis junction, and the pseudo-Jones fracture is an avulsion fracture of the attachment of the peroneus brevis tendon at the base of the fifth metatarsal. Here is a pseudo-Jones fracture marked. Jones fractures are prone for non-union and are treated by strict non-weight bearing in a plaster slab or surgery. Most of the pseudo-Jones fractures heal well and are treated with rest and gentle mobilization. Next is the stress fractures of the metatarsus. These are also called march fractures since they are often reported in young military recruits. These are commonly seen at the neck of the second and the third metatarsal bones. These fractures have an excellent healing potential and are best treated with simple rest, elevation, ice application, and a compression bandage. This is the end of this video. Thank you for watching.